Dr. Carlton Erickson, welcome to Shrink Wrap Radio.
Thank you, Dr. Dave.
Well, it's really great to have you on the show and to have this opportunity to meet you and to discuss the second edition of your book, The Science of Addiction from Neurology to Treatment, and all in about 300 pages. That's pretty amazing because you're covering such a vast area. So thankfully, it's a volume that anybody who's interested will be able to digest. You published the first edition back in 2007, and a lot of water has gone under the bridge since then, because here we are in 2018, and in the clutch of the worst, if not of one of the worst, if not the worst, addiction crises ever. I'm referring, of course, to the opioid crisis. What have you learned in the 11 years since the first edition of your book? Maybe that's too broad a question. We can break it down a little bit. What, if anything, did we have wrong 11 years ago?
Yeah, well, I can tell you've done your homework already. That's an excellent intro and background. I think in order to be able to set the stage for what I'm going to do today in this hour, and to answer your question, I have to give the audience a little bit of a background of me.
Fine.
Because I have an unusual background. And is that okay?
Yeah. You must have an unusual background because, yeah, go ahead. I won't interrupt you, but it would seem, I would expect what you've done to be more from an MD than a PhD. That's all I'll say about that.
Yeah.
Tell us your version.
Okay. Well, I am now an addiction science educator, and I wasn't always that way. I have a pharmacy degree from Ferris State College in Big Rapids, Michigan, and then I went to Purdue for my PhD in pharmacology. And after I graduated there, I was recruited to the University of Kansas, where I spent 13 years, and then I was recruited to the University of Texas. And have been here for almost 39 years. And as we discussed before, I'm about ready to retire. But getting into the field of drug addiction that was reasonable for a pharmacologist, because I like to call myself a former mouse researcher. And my very first grant was from the National Institutes of Health to do work on how alcohol produces intoxication. And I did such great work that we still don't understand how alcohol produces intoxication in the brain, because it's much more complex than I ever realized. But during this journey, what happened is that I didn't know anything about alcoholism. I'm not an addict. I'm not an alcoholic. I don't have any in my family, I thought. And so I began to attend 12-step programs in Kansas just to learn what the disease was about. And it was amazing to me to listen to the stories of the people who had the disease. And I kept that interest as I came to Texas, and I befriended a now, I think, 45-year-old alcoholic who's still in recovery through Alcoholics Anonymous. And his name is John, and he's Irish. And he taught me the early parts of what I know about alcoholism as a disease. And his first comment to me was, Carl, we ought to get together and go around the country and give workshops called Where Science and Addiction Meet. He says, you can be the science and I'll be the addiction, and we'll talk with counselors and who will ever show up, and talk and dialogue in front of them and have them ask questions, because he says, frankly, I want to know what's wrong with my brain that makes it impossible for me to stop drinking. And you said you want to know something about the disease, and what better way than to talk to recovering addicts in the audience, many of whom turned out to be counselors who were working, helping alcoholics get better. And so we did that for 5 years. We gave 126 workshops in 27 different states, 2 countries, and we learned a lot. And what I learned was that, as John used to say, he never took a normal drink. And that got me really interested intellectually as to why that would be. the case. And he said, yeah, Carl, he said, I learned from in my early drinking years that I just couldn't stop. And, there's an awful lot of people who can drink alcohol and can stop. I'm one of those. I have my 2 glasses of wine at night, and that's all I need.
Yeah.
But John found out that he couldn't stop. He kept going. Yeah, he'd have periods of no drinking when he was trying to stop. But that was the difference in it. And so we began to learn something about addiction through alcohol. And that's where I got my early federal funding for my mouse research and my rat research, which I continued at Texas. And then about 1994, I was invited to the Betty Ford Institute in Rancho Mirage, California, in their professionals and residents program. And I spent a week on the units with the patients, talking to them and seeing what they go through during what so-called recovery. And there, I was just smitten. It changed my life because those individuals were not bad people. They were not crazy. They were not just people doing bad things and wouldn't stop. They really couldn't stop.
I'll bet there were some famous people there, because isn't that the clinic that the famous people go to?
I didn't see any.
Okay.
And it's kind of a misnomer because yes, they come and go rather rarely, and it's still the case. But that was 1994. And so they had that reputation because it was so darn expensive. And it's still expensive today, not as expensive because insurance covers that, and we can get into that later. But the quick end to my story is that I came back from there and I decided that I wanted to be an addiction science educator as a scholar at the university. And I went to my dean. It took about a year to figure this out. And I said to my dean, I would like to shut down my laboratories. I had 3 laboratories with 2 federal grants, and I just stopped them, gave the money back to the government, and I started to go around the country giving talks at people's invitation, actually, because I found that the recovering people in the treatment community were thirsty for the new science that was coming out. And I was able to do that. Very fortunately, they liked my presentations. And so I turned it all over to that, and I started studying audience reactions along with a number of other colleagues. We measured changes in knowledge over 6 hours of listening to the neurobiology of addiction. And we studied their belief changes, and we studied their behavior changes. And so
good.
Published a number of articles in that, and then it just kind of grew from there until I wrote the book. And so that brings you up to date. So what did I learn? I learned a lot about the disease before 2007, and then from 2007 to 2018, I've learned that we've made huge progress in understanding what goes wrong with the brain in people who can't stop drinking. And the big deal is that we have to let everybody know, just like John, he was not a normal drinker. There are mostly normal drinkers out there, but the ones who are not normal, who have the disease, are about 15-20% of that population. And that percent changes with each drug that you talk about. So that's the big thing I learned. And then the other chapters in the book cover genetics and advances, and it's huge jumps. And so I like to think that we're on a trajectory towards finding ways in which we can not cure the disease, but arrest the symptoms and help people who are struggling with the disease now to find full-time recovery.
Now, I noticed that you characterize it as a disease, and I know that AA has done that as well. As a psychologist, I'm aware that there have been other models sort of competing with the disease model, and I think psychology in general has tried to resist things getting over medicalized, if you will. And so maybe you can talk a little bit about that. I think, other models might be an educational model. I don't know what the competing models are, but maybe you can speak to that and tell us why you feel so strongly that it fits, that disease is the right model for speaking about it.
I'm really glad you asked that question. There are 13 chapters in my book, and the first 3 are related to this issue. scientists should never be dogmatic, and I try not to be dogmatic, but frankly, I think that science has now shown us, and the evidence is in, that some drinkers, as I just described, some but not all, have the disease of alcoholism, which we now call alcohol addiction. There are other names which we'll cover in just a moment, but they're all based upon diagnostic procedures that are laid out in the DSM, now issued edition 5. Diagnostic and Statistical Manual of Mental Disorders has been used by psychiatrists, counselors, qualified assessment professionals for a number of years. And it is the Bible, along with ICD, the International Classification of Diseases, published by the World Health Organization, for diagnostic ways. And so being able to label something as a disease starts out with diagnosis. And now we have diagnostic procedures, diagnostic criteria in the DSM-5 that allow us to say, this person has an alcohol use disorder, and there are 11 criteria. And everyone who has an alcohol use disorder does not have alcohol addiction. It's only the far end, the severe end, which is 6 or more criteria, that determines whether that's the case. So I'm not the only one. I think it's about time we stop arguing about this. Philosophically, it's okay to argue, but frankly, I think that a lot of people who are looking at thinking this is not a disease are looking at the majority of drinkers who don't have the disease. And so they tend to characterize those as people who are bad, have personality problems, making bad choices, and that's all true. But they do not deserve the heavy-duty treatment that the people with severe alcohol use disorder, AKA alcohol addiction, which used to be called alcohol dependence in the previous edition of DSM-4. So the name, here's where we get into trouble. We can continue to argue, but we're all arguing about different parts of the elephant.
What's the difference between dependence and addiction? You're making a distinction there?
They are essentially the same. So in the DSM-4, I don't know how many of your listeners or viewers are aware of it, but or have studied the DSM. The Diagnostic and Statistical Manual in DSM-4, the earlier edition, characterized 2 categories of drug overuse. One was called drug abuse, also called substance or chemical abuse, versus substance, chemical, or drug dependence. And this dependence is known mostly by physicians as withdrawal. But chemical dependence is not the same as withdrawal, which is also called physical dependence. And that's an old pharmacological teaching that everybody, including physicians, know about, that when you take a drug over a long period of time, then you withdraw, you go through withdrawal symptoms, which is essentially a rebound from what the drug's earlier pharmacological effect was. So if you're talking about a depressant drug like alcohol and you withdraw, you get hyperexcitability symptoms, which include seizures, anxiety, and so forth. So that's physical dependence. And the reason that the DSM-5 came up and dropped the name dependence is that too many people were getting confused between chemical dependence as defined by DSM-4 and physical dependence. In fact, there's some old time thinking that said that the physicians just couldn't understand the difference, and that's why they started to withdraw. At some period in medicine, there was a time where physicians were withholding pain medications, powerful pain medications from terminal cancer patients and terminal AIDS patients for fear of addicting them, even though they were only going to live for another year or so. So it got to be that ridiculous. And then people said, wait a minute, you're not addicting them just because they go through withdrawal. Withdrawal is not addiction. So don't worry about addicting them. You can give them all you want, and only a certain percentage of them will need treatment for the continued use of the drug. But most people withdraw and they never want the drug again. Does that help?
Yeah, that helps. It's still, I notice in the book too, there are fine distinctions that you're making, and you really go to some length to try to clarify and explain it. Let's talk about the opioid addiction, since that is uh, so forward in the news right now, and kind of on everybody's mind, and some parts of the country just really, really serious with finding dead people laying on the streets and using Narcan to try to bring them back. So let's talk about that. And the funny thing about alcohol, going back to alcohol is legal and socially sanctioned on the one hand. And as you say, most people can handle it, but not everybody. And alcohol but that very difficult end of the alcohol has cost a lot of money and a lot of physical issues and problems and so on. So now we've got the opioid crisis. Maybe you can contrast and compare.
Yeah, it's not just as simple as legal versus illegal, because of course, many opioids are legal as prescribed, but it's the overuse by people who really shouldn't be using these outside the medical prescribing regimen that's starting to get a lot of people into trouble. And it's not an easy answer. So let me see if I can break it down as simply as I can, as trying to be the educator I want to be. There are people who get opioids legally through their physicians, through prescription, and they may take them for a short period of time. They may take them for a long period of time, depending upon the condition. For example, if you have a hip fracture, you may, that's not a good idea. How about a leg fracture? And so you go in and the pain is just unbearable. So they give you an opioid to calm down the pain. Well, generally in about 2, 3, 4, 5 weeks or so, that leg will begin to heal and you can back off the opioids. I have a colleague who had knee surgery, and he came back and he was just kind of laid up with his leg in a cast, watching television for several weeks. And I said, at the end of 4 weeks, I said, "Are you still taking opioids?" And he said, "Yeah." He said, I'm taking 1 a day. I used to take 3. He said, "I'm trying to taper myself off of them." And I said, "Sounds like you're being pretty successful." And he said, "Yeah." And he says, "I can do it. I just have to supplement it a little with a Tylenol here or there." But he really didn't want to use the opioids because whatever reason, he wasn't connecting with the opioids. And then 2 weeks later, he was totally off the opioids. Now, that's the way it should go. A lot of people will have back surgery, and they use these drugs for chronically, even before the back surgery and after the back surgery. And then for whatever reason, they continue using them, and they'll continue to go back and get their medications refilled. And the physician will say, as long as you're still having pain, that's fine. And let's all agree that there are some physicians who really don't know much about addiction and opioids, because this is not a course in medical school. It's not a course in my college of pharmacy. It's individual lectures here and there. And so consequently, many medical schools have a half an hour on drug addiction. Other medical schools would have maybe 2 or 3 hours. So one of the big problems has been, let's get physicians more involved in this and try to get them educated about addiction so they can help control the drug crisis too. And many of the medical schools are taking that on as a really big deal right now, because there are so many deaths from it, and they don't like to see the overdose either. So most of the overdoses come from people who are taking these drugs, what we call chronically, over many, many years, and months and years. And then they get into, well, the drug's not doing it for me anymore, because opioids cause a fantastic amount of tolerance, as you and your audience probably knows. And so once you get the tolerance, you want more to get the same effect you did the first time. And if you're either dependent, now I'm going to say severely use disordered, that's the new terminology. If you're severely use disordered, then you're going to continue to want to take more drugs, and you'll graduate to heroin, fentanyl, or something stronger. And now you start to get into the overdose possibilities. one of the things that opioid addicts just will never seem to learn, if they ever hear it in the first place, is if you try to get off the drug and you're off the drug for 2 weeks, you don't go back to the same dose you were using 2 weeks ago, because your tolerance has disappeared, and all of a sudden the dose that you were taking 2 weeks ago is now an overdose. That's where we get many of the overdoses from, this chronic use of opioids and then heroin.
Mm-hmm.
There are other people who start out with other drugs, or for whatever reason will get into heroin, maybe in a ha-ha situation. They're, yeah, hey, let's try this. And they've been using other drugs and they like to try out different drugs, and they'll use heroin. Hey, man, this is really fantastic. Same thing they say about methamphetamine. These are really dangerous, highly addictive drugs. And now all of a sudden they find they can't stop. And my friend John has a great phrase for it. He said, there are some people who just don't have what it takes to get addicted. He was one of those. His wife used to drink just like he did before they were married. And then all of a sudden she's not an alcoholic, and he was. And so he had what it takes. And a lot of that is genetics and what we now call epigenetic factors. We can talk about those later if you like.
Yeah. Well, let's talk about what goes on in the brain, because in the case of alcohol, you have these people who are clearly severely addicted, and it's got something to do. You said we still don't fully understand intoxication. We know something that there are receptors in the brain that are set to respond to certain chemical compounds, that like a lock and key. That's the impression that I have.
Right.
So
Yes.
So are the extremes, you talked about the disease level of alcoholism. Is it pretty much the same phenomenon in, say, fentanyl?
It's pretty much the same fentanyl, because the opioids, fentanyl is an opioid like compound, and it attaches to the same brain receptors as heroin and morphine and all the other powerful opioids. And so that's where it starts. And by the way, let me just say, I'm not the only one that is getting ready to say, let's move on. The National Institute on Drug Abuse, who funds 95% of the research on drugs in this country, their website says addiction is a medical disease. The National Institute on Alcohol Abuse and Alcoholism, their website says alcohol addiction is a brain disease. Mm-hmm. The American Medical Association has said that addiction is a disease in 1965. Now we have a new medical organization, American Society for Addiction Medicine, 6,000 physicians around the country who do nothing but learn about how drugs cause addiction. And they certainly agree that this is a medical disease. And so, I mean, there's no reason, I don't think there's any threat to anybody's theory that you can, if you say this is a disease, this doesn't threaten anybody. So many people are afraid that if you call it an addiction, then you're letting people off for the responsibility of overusing their drugs. But there's 80% of the people who use drugs that you can blame that. You can say, okay, that's a choice. You deserve what I just said. But there's 20%, this is 20% across the board because it's different for each drug. Those people who use the drugs who become addicted that don't deserve, that type of decision. So in my book, I say it very, very clearly. The evidence now shows us we can have it both ways. If you look at one subset of people who overuse drugs, you can say, yeah, they're bad people. They shouldn't be doing that. They're totally responsible for everything that went wrong with them. Whereas there's this other group of people, which tends to be a minor group, who are addicted, who have a medical disease, a lot like schizophrenia, a lot like Alzheimer's, a lot like Parkinson's disease, where a chemical has gone wrong in the brain, and now they can't stop using the drug. It is truly an out-of-control drug use situation. However, these people are still responsible for the havoc that they cause in their families and in their neighborhood. If they kill somebody when they're under the influence of a drug, they're responsible for taking the consequences of that. They are not responsible for having gotten the disease in the first place. And that, yeah, maybe they shouldn't have used opioids. but some people don't have a choice. There's a lot of people who need opioids for pain control.
Well, I
Well,
know
they never
you're
should make
very,
a
yeah,
decision.
one of the things you write a lot about in the book is stigma. And I got the impression that you see stigma as a really big problem kind of bound up in this whole addiction discussion.
Exactly. You hit the nail on the head. And I can tell you read my whole book. That's awesome.
Thank you.
And so yeah, and the reason and I'm not biased. I'd like to think that I'm a well-trained scientist in pharmacology, and that I'm a pretty critical reviewer of the scientific literature. I've been an editor. And I continue to be a reviewer for manuscripts. And scientists should be critical, but you should also be able to look at all different aspects of it. So that's why my book is so broad. You know, I try to cover psychological aspects, social aspects, and everything else. And so that's why I say, you know, let's leave the discussion and the philosophical, you know, back and forth about whether this is a disease or not to the philosophers. But you know, in my view, for that particular portion of the overusers who can be diagnosed and we can tell they have the disease, let's treat them as if they have a disease like any other disease. So it's all about stigma. If we don't believe that it's a medical disease, there's going to continue to be stigma against all drinkers and against all those people who are called addicts of anything, by the way. I don't think that being a cell phone addict carries the same amount of stigma as being an opioid addict. You just ask the people in mental health. And as a psychologist, and many of your audience members who are also listening to this, mental health has a huge stigma as well. And this is a big uphill battle that we all have to climb together, because people who are drug addicted also have co-occurring mental disorders as well as co-occurring physical and medical disorders too. So we got to treat the whole person. And I love the work that's been going on since 2000, where we have a lot of brain imaging studies that are now starting to show that when you go through cognitive behavioral therapy, for example, the brain function actually changes. When people report their anxiety is going away with CBT, their brain function is changing in step with those changes. And that's tending now to bring the psychologists and the neurobiologists together and saying, aha, we can see changes that are caused by talk therapy. Yeah. We can see them chemically. And that's the bridge to these disciplines, which have, in many cases, I'm old enough to remember, we didn't agree with each other. We argued with each other all the time. And it's okay right. for scholars to argue. But if you spread that argument to the general public, then all of a sudden you don't get enough funding for research. You don't get enough funding for treatment. You don't get enough funding for education. You don't get enough funding for prevention.
Yeah. So let's see, where else shall we go here with this? So you speak about addiction as a chronic medical brain disease. And you spoke about how we diagnose the disease of addiction. Maybe you can say some more about, oh, I know what I want to ask you about. And you do discuss this in the book, the addictive personality. That's something that's, you know, very widespread, that people have the notion of an addictive personality, and that if you happen to be cursed with that personality, you're going to get addicted to something. And if you manage to even get off that something, you'll probably get addicted to something else because you have an addictive personality. So give us your thoughts about that.
Sure. And here I'm going to have to wander a little bit away from the science, because it's to me, this is something that's very confusing for a lot of people. Psychologists tend to think of the addictive personality differently from a pharmacologist like me. To a psychologist, you said it best, that if you get addicted to one thing, you can get addicted to other things. As a pharmacologist, I look at an addictive personality is, well, first of all, is there a progressive effect? For example, if you start out with smoking, Are you more likely to go to marijuana? Are you more likely to go to alcohol? Are you more likely to go to harder drugs like opioids and central nervous system stimulants and so forth? And that gateway theory has never been proven in science. There have been articles written about it, and most of them are equivocal. They either balance out each other or they come to a conclusion that we're not exactly sure. So there's no scientific conclusion that we can draw from that. But whenever somebody says, what do you think of the addictive personality, I first ask them the question back, well, what do you mean by that? Because I can't answer the question until you define what you mean. And that's one of the problems, is there's so many different meanings of the addictive personality. You know, around the recovering community, the addictive personality is that you tend to, you like every different thing. You kind of have an adrenaline rush to different drugs, to jumping off of high heights, you know, in a kite, things like that. And so that's an addictive personality to the people, and many of the people in recovery. I don't see that in any way that happens. I think it's just a person who has a personality that they like to do a lot of different things, and that's why I call that an addiction. You see, and you know, that kind of brings me back to a point that I want to make sure I make, is that because of the stigma, which you asked me before, and because of this question, the way I try to handle that in my book is, it wasn't my idea, it was a colleague's idea. Let's call the drug addictions the big A addictions, which we have 25 years of scientific and genetic experience primarily in the neurobiological areas, and say, okay, those are the big ones that are serious. Nobody smiles when they say I'm a cocaine addict or I'm a heroin addict. But there's a lot of people who, in my book, let's call it the little A addictions, which is what the media like to focus on, Oreo cookie addictions. A lot of people smile when they have that type of an addiction. And so you can't compare the two. We're never going to get rid of the word addiction. And because of the various meanings, you know, we can argue forever about what addiction is, but we may be arguing about apples and oranges, as the saying goes. So I'm not expecting the medical community to pick up big A addictions and little A addictions, but it's a wonderful way in my book to let people know that we really don't have a lot of research on the little A addictions at all.
Well, are you including in the little A addictions, video game addiction, sex addiction?
Yes.
Those are examples?
Yes. Even exercise addiction. Right.
Yeah. Don't we know, though, that, yeah, I guess there's a fuzzy gray area here, because everything we do has something's going on in the brain, right?
Right.
So, and in the case of the big A addictions, we know maybe more about what's going on in the brain. I'm under the impression, and again, I'm a real amateur here, but I'm under the impression that there is some brain science on some of these little A addictions that would suggest that they, in fact, qualify for being thought of as addictive.
Okay, so here we go back to stigma again. And what I like to do is point out again that what the American Psychiatric Association has made very clear in their latest edition of DSM, which is DSM-5. Those activities are called, that you're talking about, that are not associated with drugs, are best called compulsive or impulse control disorders. And so eating in the DSM-5, eating disorders, obesity, anorexia, and so forth, have their own category. The exercise is not in the gambling addiction. I mean, it's not in the addiction category with gambling. Now, gambling is a unique situation where we do seem to have brain imaging studies, and even this is controversial and was on the committee who made this decision as to whether we have enough brain imaging studies to indicate that gambling produces changes in the same brain area as drugs so that it can be called an addiction. But that's the only one. For internet and for even caffeine, those are in an appendix in DSM-5 of research to be completed, not enough research category.
So it sounds like a lot of this It's not necessarily ruled out, but we need more research, because it would seem to me that gambling would get the camel's nose under the tent, so to speak.
Yes, exactly. And a number of people believe that there's enough research to show that compulsive internet behavior would fall into the area of addiction. But then I go back to that same question: is why do we have to call it an addiction? I think that adds more stigma when you call it an addiction than helps. And that certainly enhances the stigma that we are continuing to experience in the mental illness area, including the substance use disorders. So, it's all about, why do we really have to call excessive lingerie shopping an addiction? It belittles the problems that are going on with the drug problems that we know so much about. And certainly, if somebody wants to call laziness an addiction, which I've seen, why don't you prove it to me that it's not just, maybe there are a certain number of people who are compulsively lazy. Doesn't that make a little bit better difference? Yes, I know there's going to be some mental illness stigma associated with that, but let's not call it that until we have the research to back it up.
Okay. I would guess that the intent, and when people call something like excessive computer use or video game use an addiction, is the sense that, hey, there's something here that needs attention.
Absolutely.
Yeah.
Absolutely. Yeah. And but we have to, there are some people, and this is a way of making things really, really blown out of control, I think. How many mothers are scared to death that their kids have screen addiction? Why don't we just say, maybe they need a little bit more discipline. Maybe they need a little bit more parenting. Maybe they need few more boundaries in their life. Maybe the parents should spend a little more attention with these. And I'm not throwing it all on the parents, but I think you see where I'm coming from. Environmental variables can affect whether people will overuse video screens or exercise too much or things like that. There's a lot of environmental factors that are involved in that too, but only a certain percentage of them will eventually have to be described as in trouble, which we could then say, okay, they got a compulsive behavior. And other people, it's just part of their personality. It's what which is what we've spent our whole history and science trying to say is, where does normalcy stop and where does pathology begin?
Yeah, well, you mentioned genetics and epigenetics earlier, and let's talk about that then. To what extent does one parents and genetic factors influence some of the things that we've been talking about? Okay.
The most genetics knowledge that we have right now, my book starts off real easy. And let's mention it before, again, I forget to say it. This book is not designed for professionals only. It's designed for the general public. I really have the target audience of counselors, mental health counselors and chemical dependency counselors when I wrote 2007. And lo and behold, now it's being used in the health professional schools as a textbook. I didn't even expect it would be a textbook, but it's apparently readable enough and complete enough and resourceful enough, because it has over 300 references, that people can look it up and check out whether they believe what I'm saying. And if they do, then that can help them teach other people. And that's the whole purpose of the book, is to spread the information that we have, the science that we have, to other people. Not for me to make a judgment, but to present the science so that they can look at both sides of it. And that's why the book is designed in a way that they can read it. And the genetics chapter is illustrative of this, because it starts out very basic. And what is a gene? You get the old DNA, RNA stuff, and then it moves progressively through what we know about the different methods of studying genetics, the adoption studies, the family studies, the twin studies, and so forth. Mm-hmm. And it just so turns out that we have the most information in the alcohol field. The alcohol field has always had its own funding through the NIAAA, National Institute on Alcohol Abuse and Alcoholism. And there were a number of geneticists who were really interested in the genetics of alcoholism. And so that's where it grew. And that genetics has been growing over the last 25 or 30 years in the alcohol field. Not much is known about the genetics of other drugs compared to alcohol. So in many ways, the alcohol field is setting the standard for coming to what hopefully will be different conclusions, but may not be different conclusions. The conclusion in the alcohol field now is that up to 60% of all the cases of alcohol addiction, properly diagnosed, are due to genetic heritability, which means vulnerability passed down from one generation to another. It's also known now that it's polygenetic. It's not just a single gene, it's maybe 17 to 20 genes. When I talk to my genetics colleagues, many of whom have, one of whom has had a particular contribution to my book by checking out my science references and so forth. He happens to be the head of the genetics department at NIAAA. So
when you say polygenetic, that might mean that I could have a perfect storm of 20 genes that are pushing me in the direction of being an alcoholic. Is it a quantity issue, or what if I only have one gene as opposed to 20?
That's a great question. It appears, and the easy conclusion is, yeah, the more of those genes that you have, the more likely you are to get the disease. But of course, you have to drink alcohol first, and you ain't going to get the disease if you don't try the alcohol. So some families won't allow it. Some families, kids say, I'm not interested. Some kids, the parents have really brought them up in a very, let's say, I don't like to say the word strict. Maybe that's the wrong word, because this might be a good outcome here. My friend John is a good example. He had 4 children, and he taught his children from as early as they could listen that their whole family background was riddled with people who have died from alcoholism, as far back as you can count the tombstones, John likes to say. Had 2 boys and 2 girls. The 2 boys and 2 girls grew up with the same message. The 2 girls got into trouble with alcohol. The 2 boys did not. And so half of them took the message, didn't have anything to do with gender. It just happened to be that 2 of them got the message and 2 of them didn't. And they tried alcohol, and they didn't become necessarily alcohol dependent, but they did go on to have some other psychological issues. And so, and I'm fudging a little bit on this. It's not quite that simple as I made it, but that's essentially the story that John has told me and tells audiences when we used to go out and give talks together. So, and the big deal here is that some people can grow up in an alcoholic family and never get the disease, either because they didn't get enough genes, or the genes that they did get were not triggered by something in the environment. So that's the epigenetic factor.
Yeah.
And we now know that genes form proteins, and in order to form proteins, they have to turn on. There are some things in the environment that will cause those genes to turn on or to turn off. Those things could be a harmful childhood. Those things could be co-occurring mental illness like depression, bipolar, ADHD, something like that. It could also be other factors like poisons, toxins in the environment that would affect those gene expressions to be able to turn on or turn off those proteins. And then we find that there's the cause in the brain. That's the pathology. When those genes or enough drinking or drugging affects the chemistry of the brain in a certain brain area, your audience will know it as the pleasure pathway or the reward pathway. Scientists know it as the mesolimbic dopamine system and other structures of the brain. When something goes wrong in that brain structure, now we have an inability to control the use of the drug, which is the primary symptom of the disease.
You know, I'm here in California where we have first legalized medical marijuana and now recreational marijuana. And does your scientific expertise cause you to lean one way or another in relation to what continues to be a controversial and stigmatized set of circumstances?
Sure. I think that when people say that marijuana is not addicting, it's a myth. Um, all the evidence points to the fact, and this is anecdotal evidence and scientific evidence. Anecdotal evidence comes from the fact that marijuana addicts seek out treatment and they go into inpatient treatment and pay lots and lots of money to get off of their marijuana. So that tells me that there's a problem there. The epidemiology studies, of which there have been some mostly in the 1990s, tell us that about 9% of people who use marijuana at some time in their lives will develop the disease of marijuana addiction, now called severe marijuana use disorder or cannabis use disorder.
Okay.
Yeah, so about 9%. So we see them in treatment, and you know, a lot of adolescents say, "Nah, marijuana is not addicting. I can smoke it all day, and I don't have any problems." Well, first of all, they're going through a lot of changes in their lives, and it could be that their brain is not being impacted by the marijuana the same way as other people's might be, or it could be impacted even more, which is what the research is starting to tell us. So marijuana use during adolescence can be particularly dangerous. I think it's what you hear most scientists or clinicians say.
Yeah.
Yeah, so I think we got to be careful there. On the other hand, for sure, as I'm a pharmacologist, for sure, marijuana is not as toxic as alcohol or nicotine. We have no known human lethal dose for marijuana. You can overload mice and rats with it and find out a lethal dose, but no one has ever died from marijuana toxicity. Yeah, they'll die from maybe being high and walking out in front of an 18-wheeler, but that's not what we're talking about.
Right. Right. Okay. What else I guess we should talk about the future of addiction. That's something that you write about. What do you see on the horizon?
Yeah, I think that I like to be an optimist, and I like to think that we are going to be able to, through a reduction in stigma with substance use disorders, that we'll find out much more than we know right now, particularly in the areas of genetics, particularly in the areas of the neurobiology and finding the exact problem that goes wrong in the mesolimbic dopamine system, and particularly in the area of better treatments. So better treatments right now, medications assisted treatment, or MAT, which is very controversial. That's methadone, buprenorphine, varenicline, naltrexone, those types of medications. Very controversial because they tend to go against the Alcoholics Anonymous or 12-step philosophy of abstinence. But even now, many people in abstinence have admitted that they had medications to help them. And so even though it's still a great motto in 12-step meetings, and I support it, that once you're abstinent, you shouldn't be using any other mood-altering drugs because you don't know which one you're going to become addicted to, or that mood alteration might throw you back into your primary disease of alcohol addiction. I think that's a great message because nobody has nobody would like to challenge that and try to take every drug to see if they could become addicted to it. Nevertheless, we now know that there are medications that can help people who are opioid dependent, particularly in that area of drugs. Opioid dependence, there are some people who just can't get off opioids through psychological counseling or inpatient treatment. Even if they do have a lot of money, they'll go 3 or 4 or 5 or 6 times to treatment and it just won't work. But medications will put them on a track where they can begin to live a more normal life. It's like a diabetic getting insulin. The insulin is not made in sufficient quantities by the pancreas of the body, so that people have to give outside insulin to be able to live comfortably. That's what we're asking with many opioid dependent patients. And it has to be, the decision has to be made by a qualified addiction medicine physician to do this, to be able to go on methadone or buprenorphine, which is a drug better than morphine, actually, less chance of an overdose, but more costly, unfortunately. And then many people will maintain themselves for a period of time where they can go into treatment and start to wean themselves off of that by substituting a 12-step philosophy or something else for that drug. And it gives them a chance to do that. If they don't have that medicine, and we know from many examples that they'll go right back on the street and get into the heroin use scene. They'll start to use dirty needles. They'll be transmitting HIV and hepatitis and other viruses from user to user and making it worse than themselves by injecting with dirty needles. Just that scene is so desperate. We want to get them out of that scene so they can continue to get better. And there's a small percentage of those methadone and buprenorphine users who will continue to use it for the rest of their lives. People say, that's horrible. They're going to use an addicting drug for the rest of their lives. Hey, it's just like diabetic. They need that insulin to be able to stay alive. And that's the bottom line. So we used to call that harm reduction. I think some people still do, but it's reducing the harm to the individual and the people around them that we're most interested in. And I applaud that greatly. So yeah. I applaud abstinence, I applaud harm reduction strategies, anything we can do to help people. And that's why I continue to think that this is a medical disease. Not think, I know. I don't believe there's a addiction, there's a medical model for addiction anymore. I think it's a medical fact.
Okay. That could be a strong ending right there, but I wanted to ask you, are there any other countries that are doing a better job handling addiction than we are?
Yeah, there are other countries that are trying different ways. For example, in the United Kingdom, heroin is prescribed freely to addicts, opioid addicts. I've talked to some myself. They do well. Well, the one I happen to remember is that she was just humming along on a same dose of heroin every day, not escalating her dose. But she's going to die of nicotine, unfortunately. She said she just admitted she couldn't stop smoking. And so, you know, some of these experiments that other countries are trying have a lot of variables that you have to sort out. And we continue to hear about the Amsterdam experience and the Belgium experience and the Vancouver experience, where they have communities of heroin users with clean needles and free drugs and things like that. And to some extent, they really work. We don't have the research to tell whether they're going to work forever, you know, for all people. We don't have any idea how many will continue on that path of safety. Addicts are strange people. They're not bad. They're not crazy. They're not stupid. They just have a little different way of looking at things, particularly the way they can't stop using drugs affects the way they think. And we have to try to deal with that too. It's not a good, strong ending because that's a downer.
Well, actually, your book starts out with, and I wish I had it in front of me, but your book starts out in the dedication with a real message of hope, and maybe you can kind of reproduce that for us. Good, you've got the book there.
Yeah, I don't know if I can find it.
I had only an online version that I don't have pulled up right now.
I don't remember what that message of hope would be that I wrote in the book, but it's got to be that someday we'll be able to treat this disease in a way. The first step will be to treat it as heavily and as aggressively as we are cancer, heart disease, and other diseases that nobody seems to argue about with respect to whether they're diseases or not. And then, like with all diseases, we hope that we can conquer this so that fewer people will get the disease in the first place. Fewer people will use drugs overall, not just addicts. And somehow we can get this drug problem in the country under control.
Okay. Yeah, my recollection of it was very hopeful. It was saying, hey, keep on trying, basically. There is a solution out there for you. Don't give up hope.
And the answer has to be in research. You know, obviously what I'm saying, there's an underlying need for more research, because if we don't have the answers, we'll continue to argue about things.
Okay. Well, thank you so much for being my guest today on Shrink Wrap Radio. Carl Erickson, I hope that you will have a wonderful retirement, which becomes fully, you become fully retired in 3 weeks. And so have a good one.
Thank you, Dr. Dave. It's been a real pleasure.